I'll start out with a case. A 62-year-old man with essential tremor, elevated PSA, and he had negative prostate MRI that was brought over to Cincinnati. So starting to look at the MR, the first thing you see is this. Well, right there's the problem. This is not prostate MRI. This is still happening, unfortunately. And we can talk about 2D, 3D, and we have very sophisticated radiology meetings as well on prostate imaging, et cetera. But all that we can decide later. We have to first make sure we are doing real prostate MRI everywhere, not just at big centers, and quality is an issue. We'll talk about 2D and 3D later, but you can see this. There's a lesion anteriorly that was there that was never seen because it was not a true prostate MRI. So we want a prostate MR imaging, but besides that, we also want multi-parametric MRI. And so this is where I'll kind of do a little bit of my basics on what is multi-parametric MRI just to be complete before we start focal and specific imaging. It's really a combination of several techniques. So it involves T2, which is what we need for anatomy, but we also need diffusion-weighted imaging and DCE. And as you can see, I have the guy who's already reached the top as diffusion because that is really the workhorse for prostate MRI. The multiparametric MRI is highly dependent on great diffusion-weighted imaging. So let's go over anatomy first. So we'll do anatomy, then we'll do diffusion-weighted imaging, which is a little bit biology, and then vascularity, how it helps. So looking at zonal anatomy of the prostate, here's a sagittal view. And if you look at this, you can see anatomy really well today on MRI. We don't really need to. The problem originally had been that we just could not see the prostate as well on anatomies, but high-resolution MR has changed all of that. So you can see the prostatic urethra, seminal vesicles, nice ejaculatory ducts, central zone posteriorly. You've got the transition zone in the center and peripheral zone outside. And you can also see the anterior fibromuscular stroma. Now, we just divide into the base, midgland, and apex, even on MRI, and you can see what it looks on sagittal and how it would appear on an axial 2-2 weighted image. You've got the blue peripheral zone, the transition zone centrally. And as you go in the midgland, the same thing. You can now start seeing more of the peripheral zone is nicely depicted. And in the apex, you can see how most of it is all peripheral zone, and here there's a transition zone centrally. So when we look at this, we talk about when we do staging, et cetera, we talk about the capsule, but we understand, even radiologists, that there's no true capsule in the prostate, and that we're just looking at the confines of the gland because of the fibrous tissue around it. And here is an example where you can see the urethra and axial view, the transition zone, the peripheral zone, the anterior fibromuscular stroma. And I'll go through a little bit about the zones. So here, you've got the prostatic urethra in the center, the rectum in the back here. And then the fibromuscular stroma, the transition zone, and the peripheral zone, which is nice because on T2 weighted images, peripheral zone is bright. So it's nice because that's where majority of the cancers occur, and it's easier to see. And this is mostly glandular, and that's why it's bright on T2 weighted images. And transition zone has a lot of gray zones, unfortunately, still for us. So as it's a problematic area, transition zone, when it's this size, it's no problem, but as transition zone enlarges, which is where we mostly do prostate MRI, it can become quite problematic. And it becomes, there's multiple bright areas, dark areas, there's cystic glandular changes, there's stromal BPH, and what happens here, our peripheral zone gets completely attenuated. So this is what we call the word heterogeneous with well-defined organized chaos, you can say, because I will show you how we can organize it a little bit. It doesn't look very organized here, but you can follow these nodules and et cetera. But the bigger problem is this peripheral zone. You can imagine a cancer here is going to be so against the gland that it's going to be hard to see it on a T2. Let's look at the coronal. Central zone, dark areas at the base. And that's problematic because a lot of trainees, when they're starting out, they start calling everything cancer because cancer is dark in the peripheral zone, but so is central zone, right? So because of the large amount of stromal, the less glandular tissue there. And then we've got the anterior fibromuscular stroma anteriorly, which is all dark, which also can be problematic starting out. So let's look at the zonal anatomy on the coronal. You've got the central zone and the transition zone, nice peripheral zone that's bright. Seminal vesicles, fluid-filled, nice, and here's the utricle showing up. So zonal anatomy is not a problem. T2 you've got bright areas in peripheral zone and dark areas in the central area of the gland. On T1, and that's a problem, T1, everything is dark. So you would never do prostate MR just T1. Now, we do get T1 weighted images because that's an essential part of the multiparametric exam, and I'll show you why. But you can see here's T2, and in this case, there's another T1 weighted image, but you have dark central area, but all of this is bright. Boy, this looks like peripheral zone on T2. This is not normal T1, right? Because normal T1 should be dark like this. So what is this? This is all hemorrhage. And this is an essential part. We got to make sure that we evaluate if there's hemorrhage. Obviously, the hemorrhage is not so extensive usually. It's usually more patchy in certain areas. But then when you see something like that, diffusion is not so accurate. And so that's something that we need to evaluate on a multiparametric exam. Obviously, a large mass like this is not a problem. But there's a differential for that as well. But on the pathology, you can see this is cancer. What else? In the transition zone, what does cancer look like? It looks, again, homogeneous. It's low T2 signal, ill-defined. It can be lenticular in shape like this, or charcoal, smudged charcoal sign, where just you see areas like that. But again, remember, transition zone has other areas dark too. So we'll go over it. So on anatomy, T2 weighted images, here's the axial and coronal. A mass is very easy. Peripheral zone, you can look across the room, no problem. Any kid will say this is a big mass in the peripheral zone, cancer. The problem is this area. When you see on the left side, it's intermediate signal in peripheral zone on the left, and it's nonspecific. It can be seen in prostatitis. Some cancers can also do that. So that is the issue. Now, classic BPH, transition zone, not a problem, surgical capsule. Then you have this area. There's no borders defined. This is prostate cancer in the transition zone. The biggest problem is treated prostate. So with radiation, everything, even on T2, becomes black. It's dark. You can't tell where peripheral zone is, where transition zone is. So T2 is limited in that. Outside of the gland, neurovascular bundles, you can nicely see on T2 weighted images. You can see these black dots here that you can see in the 5 o'clock, 7 o'clock locations. You can follow it, et cetera. There's some variability to it. But there is limitation. The specificity of T2 weighted imaging is not there because there's a differential. You can have prostatitis. You could be hemorrhage will look like that. Hypertrophic nodules will look like that. Granulomatous prostatitis. So that's why we need to understand the biology, and diffusion weighted imaging comes in. What is diffusion weighted imaging? That's a question that everybody, when they start out, questions that. It's really movement of water. It's the water velocity that we're measuring. So if there are cells, such as in low Gleason grade tumors, cells are far apart, the velocity of water is high. And there's a different appearance. And if they're tightly packed cells, as an aggressive cancer, then it looks different. The movement of water is less, so the velocity is less. And what does the velocity, so when we do diffusion weighted imaging, post-processing, we do a apparent diffusion coefficient, and that looks like this, where there's a black hole. So black hole is basically the movement of water is not as good. So that's the aggressive tumor. So it's easy, black hole is bad. Just remember that one part. And if you look at diffusion weighted imaging in the peripheral zone cancers or transition zone cancers, again, one thing, this is acquired high B-value diffusion where cancer is bright in the peripheral zone, and it's a black hole on the ADC. Same thing. In the transition zone, large mass anteriorly on acquired diffusion weighted images, and then black hole on ADC. So this is simple, right? Black and white. Cancer is black and white. Now, oftentimes it comes up PIRADS 4 versus 5. What's the big difference? It's really the size, or if it's a small lesion and it's going outside of the gland, it becomes a 5, PIRADS 5 automatically, right? So in this case, this is less than 1.5, so this would be a 4, PIRADS 4, while this would be a PIRADS 5 on diffusion, right? Because this is a large, greater than 1.5 centimeter lesion. We will go into this later. So this is the basic biology of the tumor. Then vascularity. It's basically tumor angiogenesis, and that happens with every cancer. However, the problem is there's a differential there again. Prostatitis, even non-clinically significant cancers show positive vascularity. So what is the value of a multiparametric exam? Really, the key steps to succeed in prostate MR obviously is going to be the acquisition. how you obtain it, the experience, which is all interpretation, and then really the fortune is going to be the targeted biopsy. How good are we at this? And all of that depends on how good we are at these two things. But the problem with all of this is, overriding all of this is quality, because it really affects every component of the fortune or what we get on the targeted biopsies. Now, it's been since 2012 that we've been doing these acquisition guidelines, so to speak. So this started with the European Society of Uroradiology and then American College of Radiology, PIRADS, we did version 2. And now we've got version 2.1, which nicely shows acquisition, right? So that's not a problem. We are no longer questioning. We have guidelines across the board, internationally, globally, this is happening. But the problem is, even today, the acquisition is not push button. And so let's look at what's the issue. These are both exams done using the PIRADS version 2.1 guidelines. On this first one, there were two PIRADS 5 lesions that were read, because this was measuring more than 1.5 centimeters, and you couldn't follow the margins. But if you acquired the same image, same exam with faster T2 weighted imaging, you can follow that these are just transition zone nodules and not truly cancer. And so today, even, you can see that the smudged margin, et cetera. So that was the problem. How about this? This image quality, it's not too bad, is it? But you can do really better, because somebody may call this PIRADS 4, but when you follow it, that you can follow the margins. And that's what we're looking on T2. We're seeing how sharp the margins are. So an acquisition is really important. Now, the other problem that happens with prostate, unfortunately, is the rectal gas. And I'll show you this, because the issue is rectal gas causes so much movement that it just really, it's really like a dancing prostate, unfortunately, because look at that. I mean, the patient could be as still as can be, but with the rectal gas, you'll get, and there's many ways to how you could, alter that. Not the best ways, but we have, in France, they put a catheter in, suck the air out during the exam. That's really not possible. Most of the US centers. There are some things people give glucagon, some centers. You can do a microenema before the exam, et cetera, but it remains a challenge. For example, in this case, this was read as negative. There's a slight asymmetry here, and if you repeat the exam, there's a mass at the apex, and you can see this black and white. So repetition is, repeating the exam if there's any question is really, really important. This was Gleason 4 tumor. Now, oftentimes with acquisition, most people just ask me the question, what strength is your magnet? Because most people want to do 3T, and of course that's preferred. But the problem is this, it's not necessarily the field strength, it's really the gradients that are on the scanner. So what happens is, to get the best signal to noise and contrast noise ratio, it's really the magnetic field gradients that are important. So the newer scans have really good field gradients, not all of them. The problem is, even some 3 Tesla scanners, because steep gradients are more expensive, they do not have it. The reason is, with steep gradients, you can do stronger gradients, you can get a lower echo time, which gives you a better diffusion imaging. And as you know, that's the workhorse of prostate MR. If you get a great diffusion image, even some of the 3T scanners don't have great gradients to fulfill the complete requirement. So that's important to know. So use the strongest gradients possible. That's really the key part of this, is that you want to get a MR for prostate MR that has the strongest gradients possible. Now, let's look at the interpretation. Where's the lesion in the peripheral zone here and in the transition zone on the right? The reason is because PIRADS is all based on, it's a malignancy risk for lesions. It's a risk stratification, right? What is the likelihood of a clinically significant tumor? And it's been published, or there's over 1,000 articles now on PIRADS. It's become a single language, et cetera. And even in the most recent version, it remains a living document. Things are being tweaked. Even in the most recent version, 1 to 5 scale, where 1 is very low and 5 is very high for malignancy. And you can learn about all these tables, et cetera. But let's just go over a case. What does it look like when you're evaluating a prostate MRI? So this is a hanging protocol. We do axial T2 weighted images that I've been showing you so far. And just look at this case here. And I can just, because of time, I'll just scroll it for you here. As you can see, the bladder on the top, that's bright on T2. You can see here the transition zone is very, so to speak, ugly. It's just very chaotic looking. There's bright areas, there's dark areas, and you can see the peripheral zone is very plastered against this big, large transition zone, right? And so this is the axial T2. So when you look at this, nothing is striking, but I look at the sagittal view. Here's a sagittal view. You can look at the same thing on the sagittal scan. And it's not forwarding, but here. You'll start seeing this, where there's a BPH, there's a median lobe hypertrophy extending to the bladder base. You can look at the same thing on the coronal views. And again, the whole idea is to look at it in more than one view because sometimes areas show up better. Here's a median lobe that's going up into the bladder. Now we also do the dark, the ADC, and this is the acquired B value, high B value images. And on this, unfortunately, you'll see nothing is striking here as much. There are some bright areas, but they don't really correspond to anything here. The only thing I'm seeing here on the axial T2 is this dark area in the peripheral zone that's a little ill-defined low T2 signal nodule. And it's ill-defined, so it's not a typical BPH nodule because in the coronal view it didn't show. Now let's look at the contrast. So when you look at the contrast, initially you don't see anything, but then as you go through several, it's a dynamic exam, you start seeing contrast filling into the prostate. And what's happening is there's an area on the right side, if you look, it's brighter. And let's look at the next image where you can see I've marked these areas. So if you look at PIRADS, this would be a 3 out of 5. It's a small area. It's 7 millimeters in size. On T2 weighted images in the peripheral zone, it's 3 out of 5. And on contrast, it enhances. You don't see anything on diffusion and on coronal distance. So this is, because it enhances, because of PIRADS, this becomes a 4. So it becomes a PIRADS 4 lesion, even though it's very small because it's focally enhancing. But I really want you to pay attention to this. The problem is rectal gas. So this was, if you see phase A to P, which is a certain way of obtaining MR, you can also do diffusion-weighted imaging on a different phase, which is right to left. And here, if you look at this, you'll start seeing the area show up in the black hole right there. And this shows up, and I'll show you better on the next image rather than scrolling through it, be faster. You see the black area. So here, even the contrast helped to make it a PIRADS 4. If you have good quality, that's where you don't necessarily need the contrast. So that's where it becomes important, is how good is your quality. Quality is dependent on everything. So in this case, we were able to go around it, repeat it, and do it. So this was a PIRADS, but this is where is the lesion here? There are some crescentic subcapsular type of lesions. In this case, it's this. Certain early cancers do that. And that's why I wanted to show you why certain other images we do coronal or sagittal, because now there's biparametric MR, but there's also a fast biparametric exam, and that's where you only do one single plane. You really want to do one other plane, because sometimes you see the lesions better. That's why I wanted to bring that up. And we may not have time for this, or maybe I can say, this was a patient who had Gleason 6 on a transrectal ultrasound biopsy. When he was being enrolled for active surveillance, we didn't see anything in his base, but when you look at the apex, there was slight asymmetry. I don't know if you can appreciate that. Let's look at the next image, where you see slight asymmetry on the T2 weighted image, and this is 3 out of 5 on PIRADS. This is black and white, so this becomes a 4. And then it really enhanced to the point where it was enhancing even below the level of the lesion you saw on the T2 weighted images. And this was really, this patient was unsuitable for active surveillance. So that's a good way to triage patients as well. Now, anterior prostate remains a problem, transition zone, but there are ways to evaluate and organize that. And this is what I was showing, the lobules in the transition zone, where certain cancers, type 1, will involve only one area. You can have anterior fibromuscular stroma being involved, et cetera, and I'll just show you some examples of that, where this is single unilateral type 1 transition zone tumor, and now this is involving both the left and the anterofibromuscular stroma. Does MPMRI, do we miss significant cancer? Even with the best acquisition interpretation, yes. This is not perfect. We do miss cancers, and the problem is the mucinous types of cancers are not dark on T2, and then sometimes on diffusion, they are not restricting. So even large, obviously 3+3 and small 4 components are missed today. There's a whole bunch of stuff going on with MR quality initiatives today, and and hopefully this will come through. We now have accreditation or designation centers for personnel qualifications. Unfortunately, it does not evaluate the performance of individual radiologists yet. So thank you.